Welcome everyone, and thank you for joining today's webinar. Today's topic is one that's really at the heart of what we do here at the Observatory. Our job is to support decision makers implement evidence-informed policies, and the fundamental prerequisite for that is the availability of good data. The Observatory is currently celebrating its 25th anniversary, and over the course of our lifespan, the digitalization of health systems and of our world in general has created enormous opportunities for new sources of information, and of course, coupled with the accompanying enormous risks around data safety and security. At the same time, the questions that we are called to answer to meaningfully inform policy are increasingly complex and require the combination of different types of information. One example of that is, for instance, the effects of environmental factors on health and the utilization of health services. However, in many health systems, data on health and healthcare are fragmented themselves and difficult to access way before we start thinking about combining them with data from other sectors. So the occasion of today's webinar is the publication of a new report by the Observatory in our Health Systems in Transition series entitled Health and Care Data Approaches to Data Linkage for Evidence-Informed Policy. You can find the report on our website, and my colleague Erica Richardson will also post the link in the chat box. We started this work before the COVID-19 pandemic hit, exactly with the aim of identifying good practices in the area of data linkage that might help health systems with fragmented data landscapes rethink their policies, primarily around access to data for health services and health systems research, exactly towards this link of informing policies. And we were inspired in that thinking by colleagues at the German Central Institute for Statutory Insurance, who were based on the fragmentation of data in the German health systems, considering potential changes. And we've seen a lot of efforts towards regulatory change in that area. But in the report, as is our calling at the Observatory, we aim to provide a concise overview that introduces the issues, the possible approaches towards addressing them, and areas where collaboration might be particularly fruitful and key to take forward. There is a lot of work around that area in general, focusing on specific issues, really good work, so that our report does not claim to be exhaustive or perhaps the gold standard, but it has its particular niche. My colleague, Katherine Polin from the TU Berlin, will shortly share with us an overview of what is included in the report so that you can also orient yourself when it comes to what to look at. Of course, if you think about the fact that we started already before the pandemic and we kept working at it, we know that at the same time, partly because of the pandemic, a lot has been happening around health information systems, data governance, and access to data for research in member states, at the European Union level, internationally. So what we have done today is we've brought together a wonderful panel, stellar panel of colleagues who will highlight for us just a couple of examples of recent advances in understanding and improving the data landscape in and around health and healthcare. And we will start with Kyrillos Atip, after Kate has presented the report, with Kyrillos, who works at the Data Science and Digital Health Unit at the WHO Regional Office for Europe, and who has been instrumental in putting together a comprehensive report on the digital health transformation in European systems. It was launched at the Porto Symposium on Digital Health a couple of weeks ago, including the issue of data governance, and he will enlighten us on this. We'll also have Nienke Schutte, who is a scientist at the Belgian Public Health Institute Cienzano and is a key expert both in the Population Health Information Research Infrastructure, or PHIRI, and at TEDAS, the Joint Action Towards the European Health Data Space. She will reflect in particular when it comes to the secondary use of data around the European health data space efforts. And then last but not least, we have Alexander Degelsegger Marquez, who leads the work on digital health and innovation at the Austrian Public Health Institute, PHIRI, and will enlighten us about relevant advances in the Austrian health system and what we can learn from their success. We also, as always, want to hear from you, and we ask that you give us your experiences or your comments or your questions to our panelists and speakers, and use the chat box for that. My colleague, Eric Richardson, will be keeping an eye on the chat box, and at some point during the webinar, we'll bring in the synthesized information that you will have put there, and we'll feed it back to the group for discussion. We have only 1 hour, as always, to do all of this, and it's my job to keep us going at the pace to achieve it. So I apologize in advance to my panelists for any rudeness on my part trying to fulfill that task. And without further ado, we can start the proper webinar. Before we go to an overview of the Observatory publication, I pass the floor to Erica with a poll for all of you. Erica, over to you.
Thank you very much, Dimi. Yes, if you could launch the poll. We've just got a couple of questions for you to get you all warmed up, and so we can get an insight into where you all are. And the first question is health data routinely used to inform policy making in your country? And that's just a straightforward yes, no question. And then the second question is, what are the main barriers to data linkage in your country? So is it the lack of investment in routine data collection? Is it data protection and privacy concerns, access limitations for researchers, the completeness of data sets, or indeed none of the above? So let us know your thoughts. And Dimi, back to you in the studio.
Thank you very much. Thank you, Erica. And thank you all for filling out the poll. And we'll take a look at the results after Kate's presentation. So Kate, if I can invite you. You're at our research hub in Berlin. You were one of the key people putting the report together. It's a concise report, but it's very rich. So your task of summarizing the content over the next 10, 12 minutes is really not an easy one. So I pass over to you. Thank you.
Thank you, Dimi, for the introduction, and hello, everybody. As said, I am Kate, and I'm a research fellow at the European Observatory, and I'm happy to be here today to introduce you to our new hit, Health and Care Data, Approaches to Data Linkage for Evidence-Informed Policy. I hope to provide a good starting point for the exciting discussion ahead. So Dimi just provided us with a general background and understanding of both this report, as well as why data linkage is important for us to study, including that it can be a tool to answer the increasingly complex questions posed to health systems researchers in an area of increasingly diverse and dispersed available data. Because of this backdrop, as Dimi said, we undertook to study the current practices in data linkage related to health systems research across countries. To do so, we employed a cross-country approach in collaboration with country health systems experts, supplemented by extensive desk research. Data linkage is complex technologically, regulatorily, and the like, and it is helpful to exchange knowledge and current ways of doing things. This hit, with its 10 chapters, therefore has 2 aims: to compare existing practices of data linkage for health services research in high-income countries in Europe and beyond, and to identify lessons and provide policy examples to inspire countries looking for possible or alternative approaches to data linkage. In terms of our methodological approach, we looked at 13 countries, high-income countries worldwide, and 30 case studies within these countries, ensuring a mix of geographies, a mix of health system organization, including insurance models and degrees of decentralization of service provision and health system management, and a range of data availability practices and use cases. We looked at interesting examples of relevant initiatives based on discussions with our experts, emphasizing those which represent data linkage across sectors, as well as electronic health or patient records and registers. To understand the case studies and make them comparable, we came up with a conceptual framework, which you can see to the right. For brevity today, I won't go into detail, but take a look. To give context and background for each country, we also created a brief country profile with relevant country and health system features. To the left, And you can see on our right is a profile created based on the conceptual framework, which captures both the data types laid out by the conceptual framework and approach, and tries to capture and answer questions related to data content, data collection, storage, and research use. These are the countries and the case studies within them that we looked at. I'll give you a few seconds to get a sense of the scope of the hit. What we found overall was that the possibilities in data linkage in a country are related to country context, such as healthcare system organization and data protection standards and cultural attitudes towards privacy and data protection. Further, the 30 case studies that we explored roughly fall into 5 categories. The first is large administrative data sets, which make it possible to map questions about the care process of individual patients across sectors and offer possibilities for linking to other data. One example from our case studies of this is the National Health Insurance System and the Health Insurance Review Agency in the Republic of Korea. The second category was centralized locations that merge existing data sets of different data holders and with variable content. Here, data remain with the data holders and are linked on request or can be stored in a consolidated database. So there's 2 sort of subsets of that category. An example is the Health Data Hub in France. A third category was databases which combine routinely collected data and make it available to clinicians and researchers, for example, the Scottish Primary Care Information Resource. A fourth was the patient-centric electronic platforms that allow, among other things, patients to gain access to their own information and which could potentially be considered as a basis for clinical data for research. For example, the electronic health files in Austria. And the fifth category we saw were tools that facilitate research across multiple data sets. An example here was the Regional Clinical Quality Program in Denmark. We identified several case studies making good use of routinely collected data for health systems research. Of note, the likelihood of data being available for secondary research rises if there is a central point of data collection or if coordination within the health system exists. Examples of case studies allowing for secondary use of comprehensive intersectoral data were large administrative data sets that link data from different sectors to fulfill their primary purpose, such as the pharmaceutical benefits schedule in Australia. There's also the merging of routinely generated health data into new databases for secondary use, such as the clinical practice research data link in the UK. And the third was the linking of independent data sets as a model. For example, the social data linkage environment in Canada. Countries also had different approaches to technically linking data. For example, we found a linkage with unique patient identifiers as a model, but also examples of using other identifying characteristics. This is interesting and important as it is often assumed that data linkage options are limited without a unique patient identifier. And for some countries, it can be quite problematic to generate a unique patient identifier. Importantly, countries which did link without using the unique patient identifier do work to ensure, of course, that these data cannot be traced back. Additionally, data linkage responsibilities across the health system was found to vary. This is in terms of who or what agency collects the data, links the data, stores the data, and shares access for researchers. However, one commonality was the use of and the deployment of a trusted third party. We also looked at how researchers' access to data is made available and found some commonalities across the countries. 3 possible access routes were identified. There was one, the direct data transmission, which requires an appropriate data protection and data security concept. Then there's the in-house evaluation model occurring at suitable host workstations of an institution holding the data. And then there was remote query, possible on separate servers and by remote access via VPN connection. As mentioned, we specifically looked at electronic patient or health records, especially as these are often a key element to the implementation of a country's e-health strategy. We found mainly that there is a dichotomy, an interesting dichotomy in how countries think about participation in and access to these tools. So on the one hand, there's the model of everyone in a country or in a health system being obliged to participate or specific, and if not, to specifically opt out, the grounds of which vary and the procedures of which vary across the countries. On the other hand, there's the model in which individuals must opt in to participate. These different operating principles likely influence the outcome of the number of users of these tools and reflect general cultural attitudes towards privacy and data usage. We also looked at considerations in privacy and data protection for the secondary use of health data. Just as one caveat, this, as Dimi said earlier, is not a comprehensive legal analysis of policies in place. We are not experts and have only tried to capture and provide an overview of the cornerstone concepts and tensions and explore sort of overarching themes in the data protection frameworks existing in countries. It is worth noting, again, that the WHO Europe recently released a report in which they looked at data governance and strategies. And as Dimi said, I hope my colleague Kyrios will speak to this a bit later. It is, in any case, a very important reference. Briefly, from our exploration of this topic, we saw that, not surprisingly, there's no common policy approach to regulating personal digital health data. Some countries have comprehensive legislation for health data, privacy specifically. Others absorb it into a larger framework. Some have both. Some countries also, data governance frameworks seem also to be aligned with the administrative structure of a country. However, similar principles do underline most country approaches, as these are informed by international commitments and regulations or guidance. Data protection considerations within these frameworks may be separated, or were found to be separated broadly, into two categories, one related to data content and data processing. Data processing itself was separated into three procedures or phases related to data collection, analysis, and sharing, and how these two categories and these three procedures are defined and regulated facilitate or undermine sharing across borders. From moving to country examples to international initiatives, there's a lot of activity around cross-border exchange of health data right now. Here are just some examples from the EU, affecting, of course, only EU member states, but I'm very happy that my colleague Ninka can shed more light on this shortly. And again, as Dimi said, we're developing this project in the midst of and throughout COVID, and we must acknowledge the innovation in data generation, usage, and practice spurred by the COVID pandemic. For the purposes of today, I won't delve deeply, but the HIT does present examples of innovations in new sources of data, new data linkage activities, innovations in data access and sharing, as well as in the integration of COVID data and the deployment of electronic health records, and a lot of activity around international data linkage and sharing. This brings me to some of our conclusions in this expansive report. The HIT presents a number of criteria that need to be met to enable meaningful healthcare research based on linked data. It also discusses the main desirable tenets of relevant regulatory frameworks. It showcases the limitations of coordination in linkage hubs and electronic patient records, and provides options for policymakers. We also emphasize that while innovative modalities of collecting data like electronic health records are important, it is also good to highlight continued investment in the potential of routine data. And just one last note, this is, as Dimi said, a quickly evolving and dynamic topic. As we are committed to updating our work, of course, but we also want to recognize the importance of ongoing initiatives like PHIRI and TEDAS and the work of our colleagues at WHO Europe, who are actually shaping and thinking and shaping the thinking and practice and the outlook of these questions for the future. And I very much look forward to hearing from them now. Thank you.
Thank you very much, Kate, for this concise and to the point overview of what is in the report. I saw while you were talking that there's a lot of activity in the chat with people asking about whether we investigated that element, and I'm sure when Erica brings us back later, she will reflect on a little bit of that. For those things that we won't manage to answer, just click through the report and you'll get your answer. Some of them are impossible to answer. So just perhaps to say very briefly before we go to Kyrillos, who is ready, two things. One is that we had a very, very committed group of country authors who helped us collect the information, look at the information, and put it together. So a big, big thanks to them for all their work over the years. And then last thing before we go to Kyrillos, sorry to keep you waiting. Erica, you wanted to briefly show us the results of the poll?
Yes, thank you very much. So very interestingly, a third of the people who responded said that health data was not routinely used to inform policymaking in their country. That's particularly of interest to us because it shows that there's still scope for work of the Observatory around Europe and even beyond, looking at some of the people in the attendees list. But when it comes to the main barriers to data linkage, I think it would be safe to say all of the above would be the most frequent one, but particularly data protection and privacy concerns. That seems to be the real leader, but all of these barriers seem to be barriers for many, many countries. So very interesting. Thank you very much for that, everyone.
Thank you, Erica. And I think this also highlights the point of having all these aspects in the report, because our intention was for perhaps countries to go in and say, we have a similar structure in our health system, which is why in the back we have the short descriptions of the structures of the health systems with country X, Australia, for example. And they seem to have solved this problem that we also have that way. So maybe this is a way that we can think about addressing our own challenge. But at this stage, Kate, thank you very much. We come back to you in the panel discussion. At this stage, and when it comes to working with countries and countries learning from each other, we go to our colleagues at WHO Euro with Kyrillos. You've done an excellent and very comprehensive overview of what's been going on in the region, also in that area. So over to you. Tell us what you've been working on. Thank you.
Thank you, everyone, for the invitation. So I will just go with a quick overview of the region. So the WHO European region covers 53 member states with nearly 1 billion people. The 1 million people have different health situations, but the countries also have different digital health situations and trends. And it is important also to touch on the fact that COVID-19 had brought what's called the digital health fever around health data. And this is basically the ability to have real-time decisions was kind of based on the ability of the member state or the country to extract the data and analyze data in real time, which is actually the reason why the secondary use of health data or data reuse and data linkage is a really, really important topic, which is the topic of today. So I will go really briefly with some highlights from the recently published reports. So in terms of data governance or digital health data governance, we have 83% of member states reported that they have a digital health strategy or policy, and around 79% have health information strategy. And 93% actually identified that enhancing access and reuse of data is a strategic priority in those strategies and policies. And it is important to note as well that 60% of the member states reported having developed an overarching national data strategy that regulates big data and analytics. Looking into the electronic health records where most of the data is being generated, and it's the heartbeat of the model medical care, around 91% of the member states have reported the legislations regarding the national electronic health records, and around 87% either have a national electronic health records or a regional or local electronic health records is being interconnected together or through a patient portal. This number actually increased from the last survey in 2015. So right now the number of countries is 45, but previously in 2015 it was 36. Again, like having electronic health records is one thing, having the electronic health records interconnected and talking to one another is another thing. And this is also important because we need to look into interoperability in that sense. So 86% of countries reported that patient information was shared from the electronic health records in primary healthcare practices with other professionals. And to facilitate this sharing, the standards such as ICD-10, DIACOM, and HL7 were the most prevalently used in the region. And we also can see that there is an increase in SNOMED CT in all the regions, with the exceptions on all the subregions, except with the exceptions of Eastern and Southern Europe. Looking to the data sharing and access from the report, it's actually great news that 100% of the all member states have passed privacy legislations, and 91% reported having legislations to protect the privacy of individual health-related electronic health records in the electronic format. And 86% have legislation that allow individual electronic access to their own electronic access of the patients to their own health records. It's also important to note that 86% of the countries, 89% of the countries reported having implemented a secure identification of patients for healthcare, and this is the unique identifier. And upon request, it's very important to note that that the patient should be able to access, but also do modifications and corrections and choose whom to share the data with and demand deletion. So in terms of from these four categories, the top two is access and demand corrections, but we can see that it is much less extent in terms of number of member states that allow patients to choose with whom to share the data, and much less extent is the demand of deletion. So this is kind of the overall quick brief of the report. The report will be shared in the chat, I believe, and I'm happy to have any questions if you'd like. Over to you, Demi. Thank you.
Thank you very much, Kyrillos. I'm sure we'll take the opportunity also in the discussion round to come back to you with questions. One question that I would think about, it's not for you to answer now, it's just thinking about this issue of patients consenting for their data to be used and looking at it from the research perspective. Of course, this gives us, let's say, imbalances when it comes to what data, the data set that we would get from an electronic health record application contains and how representative they actually are for the population, if we consider that some patients, for different reasons, might be more likely to not want their data to be shared. So from the research perspective, this is a challenge. From the ethical perspective, this is really paramount. So there is a lot to be discussed around how we actually merge these two things together. Something to think about. Perhaps we'll come back to that during the discussion round. So I thank you. At this point, we'll make sure to put the link in the chat. It's a really, really interesting report. So I would really encourage everyone to go and look at it. We come back to you in a moment. Before that, we move to our neighbors, Cienzano here in Belgium, to talk about not their Belgian experience, but rather the experience around the European health data space. With TEDAS, Ninke, we come to you. There's a lot about the secondary use of data there. We have people in the chat already asking about the European health data space. So enlighten us, please. What have you been working on in the past few months? Thank you.
So yeah, my name is Nienke Schutte, and I am the head of the Health Information System Unit at Cienzano, the Belgian Public Health Institute, and indeed the neighbors of the Observatory. And Cienzano, being the Belgian Public Health Institute, is a research institute. This is important. So in my unit, we are leading and participating in many European projects and also national projects in health information, and we're aiming to facilitate the exchange of health information across Europe. And the joint action TEDAS towards the European health data space is one of them. And also the research infrastructure PHIRI is one of our flagships. And I'm very grateful to be inviting you for her 3-year anniversary this coming Friday. So today I would like to shed some light on the matter from the perspective of these 2 different projects. So the joint action TEDAS and the PHIRI research infrastructure. What do these 2 projects have in common? Well, in both of these projects, we did assessments of national health information systems. We focused on reporting the current state of play of the health data management systems that we did in TEDAS, and we mapped the health information systems that were set up to accommodate COVID-19 data and health information flows in PHIRI. So in the few minutes that I have, I would like to focus on the research perspective. And I would like to share 3 barriers that researchers face when it comes to data linkage, and also how countries are working on overcoming these barriers. So first, so we all know the obvious reasons why we should link data sets, and especially in the domain of public health, as deterministic health models cover elements from social, economic, physical, and now even digital environments that in turn interact with individual biological factors. And in this case, researchers require data from very different data sets and data sources, and this data needs to be linked at individual level. In TEDAS, we saw that 9 out of the 12 countries that we assessed have a unique personal identifier, which was already mentioned before by Kate, that was used to collect health data, and that can in turn be used to link health data. However, we also learned that even in countries where there is a unique person identifier, some legal and interoperability issues make the linkage of data sets at individual level challenging. However, in most of these countries, new legislation is coming up, either to use the unique person identifier for health data, as well as extending legal mandates to allow linkage of individual level data for secondary use of health data for policy and for research. Second, if we take a look at the COVID-19 assessments that we did in PHIRI, we noticed that many of the data flows and also data linkages that were set up were initiated as part of the emergency legislation. And a lot of concern was raised on their long-term use, and of course the possibility of such data being destroyed after the emergency status in that country ended. And this could result in the loss of very valuable information about the virus, but also on the direct and indirect effects on population health. And moreover, a lot of the countries lacked plans on how to integrate the newly developed systems into the systems that were already in place and to really capitalize on the investments done during the pandemic. However, some hope on the horizon. Countries are working on stronger pandemic preparedness plans, for example, supported by the Recovery and Resilience Facility of the EU, and trying to incorporate new developments to make sure that these innovations are not lost. And I think it was also highlighted by my colleague, Kyrillis, that health information strategies focused on big data analytics are now taking up in national strategies. Finally, third point, in many countries, general data linkage across many main health data sources is possible, but this is mainly project-based, which means that after a research project ends, the linked data is lost. And in countries where data is linked structurally, for example, in some of the Nordic countries where you have a lot of registers, might be less of a problem. So what can help? Good summary statistics, but there are also some more innovations to overcome these barriers. For example, creating high quality synthetic data that can be used as a proxy, for example. And to conclude, I think these 3 barriers should be taken into account when you talk about strengthening national information systems. And this goes both for preparedness plans for the next crisis, so the next health challenges, but also preparatory activities for this upcoming European health data space. And this all to support research that in turn underpins health policy decisions. Thank you, Dimi.
Thank you, Nienke. Sorry, too many mute and mute buttons here. I'm confused. These are really crucial barriers. One thing that I pick up from your last point, perhaps also for you to think about, maybe we'll come back to that later, is this issue of accessibility of data for research and the fact that you can link. Even if you can link, it's project-based, so then the linked data set gets lost or is destroyed. There's another element, we reflect on that very briefly in the report, but it is really important, which is the barriers to access to this data when it comes to setting up the project. So if it's really convoluted and difficult to get access to the data, if you have to go through many hoops to actually get the data set that you need to analyze, this discourages researchers from actually doing that. So there is this additional dimension of ensuring that access to data it can't be simple, but it is at least simplified to a degree where it's conducive to using it regularly for informing policy. So I don't know if there is some additional information on that. We come back, I think, to this issue in the discussion. We thank you for now. We're keeping an eye on TEDAS anyway and on your event on Friday, for which we have the link in the chat, by the way. To those of you who are interested in joining, you can join remotely. And we move for now to a different country in Europe, to Austria. And Alexander, you've had quite a few developments in the last few years when it comes to data and digital health. Your institute only now, or recently, 2 days ago, basically celebrated its 50 years. So you have a long track record of informing policy in Austria, but perhaps not such a long track record of the digital data use. So perhaps you can give us a little bit of advice on how to go about combining these two things. Thank you, Alex.
Thank you very much, Dimi, and hello, everybody. It's a pleasure to be here. Yes, so in Austria in general and in my institute's 50-year pathway, we certainly on what is possible and what can be done already in terms of evidence-based policy making in health, and also a good share of what cannot be done. So to give you a quick outline of where we stood in a pre-pandemic world, Austria, in terms of the primary use system, has a functional national electronic health record system, ELGA, which is rolled out. It's in the field. It has a lot of flexible customization options for patients. They can access the information. The health professionals can access the information. It's focused on healthcare provision. In terms of the planning side, at my institute, we have been developing over the last decades an Austrian health information system. At its core, it has a set of now linkable, individual level linkable data on inpatient and outpatient sector diagnoses and billed services information, which is very crucial, of course, for planning purposes. There is also information on causes of death, socioeconomic data, cancer statistics that is processed within the health information system, but these types of data are not linked at an individual level as of now. The pandemic, of course, changed a few things. We learned a lot of what we would have been doing, we would have needed to do years ago. So, for instance, it was very tricky to come up with a solution to get live data or more or less patient capacities. We managed to find a way around somehow. We also learned the hard way, so to speak, how to combine epidemiological data on infections with epidemiological data on vaccination to have information on vaccine breakthrough infections, for instance. There have been developments, and this is very nice in terms of the interface to the research world. My institute hosts the COVID-19 data platform, where you can access COVID-related data under certain conditions. And we have a national microdata center at the Statistics Institute, which has some health-related data accessible as well. So this is what's in the field. And now to come to the second block, which is sort of where are our limits and where are we working right now. So one big topic is that the whole world of the electronic health record data, the ELGA data, is outside of the scope of reuse. This has a history in long and very tough discussions when ELGA was born around data protection, and it's basically still the same, that this data is not touched for reuse. The only thing you can do at a very aggregate level, you see some admin data on where do discharge reports pop up, etc. Interestingly, if you look at this report and other reports and what we've been publishing, we have data on medication, we have data on causes of death, we have cancer registry, we have diagnoses and service data, but they are all separate. So for us in Austria, the challenge is not so much that we have a lack of data. You can always discuss completeness, quality indicators of these data. But the principal working that we have to manage and where we have to get better is public interest related data linkage. How do we allow that? What is required to achieve it? So we, in principle, have a very smart e-government system where we have a unique patient identifier that is different from identifiers in other sectors of policy. which for data protection, privacy reasons is a smart idea and it works fine. But we don't use this patient identifier throughout. So there are some technical barriers for linkage, and then there is a lack of a trusted governance mechanism and legal grounds for when we can link this data. So we are working now on finding a way to define these governance mechanisms to do the job on the backend side, so that the systems actors have the data they require for planning and monitoring what's going on, and to decide the interfaces with the research world outside of the decision maker support that job, of course. So it's important that we push this discussion ahead, and for that reason, we of course are very interested and very engaged in the discussions around the European health data space, which will be, I think, a very relevant development for all countries within the EU and possibly within the region. Thank you. That's all from me for now.
Thank you, Alexander. Just a clarification to make sure I got this right. So you have the ELGA data, they're not available for research. I think there was in the beginning a discussion when the application was born that perhaps they would be, and then its popularity basically plummeted overnight. If I remember correctly, the context. In any case, that is one thing, but the point that you bring out about this having good data, but they are somehow siloed, and the real challenge is actually getting the public case for linking them together. The problem or the challenge or the obstacle is the regulatory context around them, or is that true? Would that then require more a regulatory change? As you said, you're trying to figure out a way to work with it somehow rather than around it. But I wonder if that's the case, because it was exactly the reason why we did the whole work in the first place.
Absolutely. So you require regulatory change, for instance, to make the build services and diagnosis data linkable to other sources, because there is a different ID is used there. And to make the regulatory change, you of course have to overcome institutional barriers, because people have to agree in order to put the regulation forward.
Yeah, there's the link between stakeholders, all the important stakeholders, and the actual regulatory framework. Okay, thank you very much. That was really enlightening, and also very grateful for your contributions to the report. And can I ask our colleagues and moderators to bring all the panelists to the plenary, to the floor, and perhaps Erica, we come to you in a minute to let us know what's been going on in the chat. From what I've been seeing here, the numbers popping up, there is quite a bit of activity. What I will come to the panelists with in a second is this idea that we heard already across the presentations, the different levels working together, but perhaps from the standpoint where you are right now, it would be really interesting for us to see where you see the potential of increasing that or intensifying that, and perhaps also what role you think that we can play as the observatory. I don't know if there are any reactions on that before we go to our inputs from the chat. I mean, I will perhaps break the ice myself by saying we heard Alexander at the very end of his presentation saying about how interesting it is to keep looking at the developments around the European health data space, and I'm assuming that Nienke, that ties with your work on TEDAS. So I think maybe you can reflect a little bit also on the timelines for that, and what we can look forward to in the next few months, perhaps.
Yes, thank you, Dimi. So what we did in previous years was were these health information system assessments. We did it in several projects, and actually the report that you just published as an observatory about this data linkage actually contains also the elements of the assessments are coming back here. So we actually see a very nice development going on. We can even see do some comparative analysis maybe in that, and we're also looking forward to the start of TEDAS 2. So the follow-up of TEDAS, where TEDAS, the first joint action, actually provided recommendations for the legislative proposal for the European Health Data Space to the Commission. TEDAS 2 will focus on the implementing acts, because we see in the legislation that there are some things still unclear, and this implementing acts will really be key for countries to start getting ready for the European Health Data Space. We will we're aiming to continue also doing these assessments, because we did it now only in 12 countries, but we see that in other countries there's also the need to do so, especially because this renders a lot of best practices that we can put forward. I think here what my colleague Alexander was telling, this is very interesting, but this information needs to be shared between countries, because only that way that we can learn and we can see other countries can see how to implement this, starting these big national strategies that Kirilius was mentioning earlier.
Yeah, thank you very much, Nick. And I think it's also impetus for individual countries to take stock of the situation across the territory, right? So, Alex, I see you have your hand up, so over to you.
Yeah, so just to support Nienke, and I think it's very interesting across the whole region that we all get a bit better in being able to demonstrate the public value of a certain reuse of data. So because it's, for Austria at least, it's a very hard cultural shift from saying, okay, the data per se is closed, and under certain requirements and under certain conditions, you may be able to use it for certain aspects. But the game-changing thought, I think, is to think, okay, in principle, the data is to the public benefit. And if the potential value of a data use outweighs the potential cost because of a data breach, we should be able to do it. And I think we need an international exchange on these indicators. Okay, what's your experience in using that data? Did it go wrong? Did it go right? What did you learn? What of it?
Yeah, and also the huge area of communicating that to the users whose data you will be using. I think, Kirilius, you have a specific and complementary perspective to bring in, because you also have the overview of the entirety of the European region, and I'm sure that's not something that is homogeneous when it comes to the different parts of the region.
Yeah, I agree with both Alex and Nika regarding the presence of regulatory barriers, basically. So sometimes the infrastructure is there. So the problem is not the availability of the infrastructure or the use of interoperability standards, but rather a regulatory blockage where, like, for example, maybe a country requires a signature for data to be reused, or the data is available but not in the format. So like having so many formats that's not reusable or recyclable or not machine readable is something that we also see during our HIS assessments. Many cases, because the electronic health records were designed for primary use, the output of that is going to be something like a PDF or something that can be printed, rather than data that in an XML format where it can be exchanged between two different systems, or like the system have an API where we can extract the data and basically aggregate the data from different sources. So again, the aspects, and this is something that we see over and over again, whenever we have regulatory issues, most of the time when we look at the secondary use of health data, we're like, why researchers or policymakers are not able to access the data? It is mainly due to data protection regulations that are not geared for that. Over to you.
Thank you. I think that's a great point. I think it all ties together. Kate, I don't know if you want to briefly. We have in the report some examples of how data from the different initiatives have been used, right? But I don't know. I don't think we go up to the point of making the public case for actually increased use of data in the different countries. But I don't know if you want to weigh in on that at this point.
No, you're right. We don't go as far as making the public case, but I find that to be a very compelling suggestion of a task. And of course, we have examples of sort of in the data protection also, and during the COVID kind of actions that countries have taken to circumvent or adjust the regulatory frameworks to overcome these barriers. So I think one thing we could do is think about how to pull these out in a compelling way, and to share that.
Thank you. But again, I think again the comparative element for that is really strong. And linking back to what colleagues were talking about, for some of these questions, a report like ours or like the one from WHO Euro or the case studies from TEDAS are really useful for other things, like thinking about how we work around certain problems, we need a much more alive format. So I think we'll think about that a bit. Erica, let's come to you to give you the chance to give us a bit of a feedback. There's a lot going on in the chat of what the colleagues have been talking about.
Yeah, there's a lot in the chat, and some of it's quite specific to different speakers. So if they wanted to go in and answer it, then please do. Otherwise, I have put in links to the full reports where you'd get more information. But two of the things that have come up quite a bit are around the GDPR compliance. And how does data linkage fit with GDPR compliance? And the role of the EU health data space in that. So yes, if we could go into a little bit more background on that. But also, what are the solutions when it comes to the challenge of data standardization and the challenge of interoperability? Like as Kyrillos was talking about, how do we overcome those barriers? What are some of the solutions? So back to you, Dimi.
Yeah, so I see. I mean, one of the issues really is this point of interoperability, right? And I think Kyrillos, perhaps we start with you in this round to give us a little bit more of a flavor of what you've seen. We've seen in the report. I think this is something that we've kept discussing and we've been discussing for years, and we hear that, like in your report, that we have different levels, perhaps, for example, of electronic health records. But if you have a local one, does it talk to the other local one? Like all these little questions. It's not about only from the European perspective whether the systems in the individual countries will be interoperable with each other. It's also within the countries that the systems perhaps don't communicate. So this is one thing. And then perhaps also the variability when it comes to infrastructures, because there as well, I'm sure we see quite a big span. So we come to you, and then perhaps colleagues wanna weigh in on this, and then we can talk about the whole data protection issue. I think there's different nuances in the chat if we get that.
So I think to start with I think let's start with the strategy first. So like when looking into the number of member states who have a strategy or policy, like a standalone interoperability strategy, there are only 56%. Almost half of the member states, or a little above half of the member states, have a standalone interoperability strategy, and that's basically specifying like who's responsible, how we are going to measure the progress, which standards we are going to use. So this is kind of the starting point. So we need to agree first on this. There are so many solutions basically. So some is through agreements and through like how to have a compliance system in place where like whenever there's a new development in the country or new innovation, they make sure that they are using the same standards as the country, so that the data that is generated from this technology, whether it's a mobile health app or a telehealth platform, is interoperable. So that's one thing. The second thing is related to having a platform basically for interoperability. So there are many solutions, not like one single solution across the region. But what is really needed is actually having that in place, like having the strategy in place and having an organization responsible for the implementation and compliance. Over to you.
And that would be at the member state level or at the country level, or do you think about this more also at the coordinating level?
Yeah, definitely. So that's actually a really good question. So it should start at national level first, and then for the data to be cross-border. And I think this is going to happen anyway with more countries adopting the European health data space in the EU. Maybe later non-EU countries who would like to have it or exchangeable with EU countries. At that point, they might need to opt to similar standards. But this is actually something that I know, and I think Nika can speak a bit more about the European health data space. But like one big project of the European data space is also secondary use of health data and how that is being shared across Europe and the governing bodies regarding secondary use. So that's actually quite an exciting thing. So it happens on both national and regional level. Over to you.
Thank you for that. I think, Nienke, you've been working quite a bit on this yourself. Maybe a brief reflection from you. I'm being reminded that we need to wrap up in time and we only have 5 minutes. So I'll ask you to be brief so that I can hear from Kate and Alex as well. Go for it.
Yeah, okay, I will keep this quite short. So indeed, so the European Health Data Space will provide easier access to data, as there are some elements in place to do so. For example, a national contact point, a national catalog, so you can actually find the data, but the interoperability issue always stays. However, Kyrillis is talking about regional initiatives and national initiatives, but there are also international initiatives, and I think it's good. There's a very nice comment in the chat by Luc Nicola, because I think he is even leading this consortium, that ICShare project that comes up, and Horizon project in 2024. So really focus on building this key interoperability profiles, starting from primary use of data, but also very relevant exercise for secondary use of data, because it all starts, of course, at the moment that you collect data. If you already collect it in a standardized way, using it for research and linking it will be much easier. That is where it starts.
Thank you very much, and for the very clear reminder to the overall topic of the webinar today. One thing that we can do, perhaps, colleagues, is, because we do have indeed a number of interesting links in the chat that didn't come from us, that signpost these different initiatives. It's when we pull out the chat for the Observatory YouTube channel, we can put those in the notes for people to look at later. Alex, I'll come to you before going to Kate for a final word with a slightly different question, because a lot that's been going on in the chat has to do with data linkage or data informing policy, and whether we can actually have or share examples where specific instances of linked data have informed policies, or perhaps a reflection from Austria on that, or from your overall knowledge, before we go to Kate and we close.
Yes, they have. In the pandemic, this was a very rapid cycle. So these breakthroughs of being finally able, for instance, to look at vaccination data together with infections data was crucial and informed a lot of policies. And on the long term, there are 2 or 3 cases. Feel free to approach me to explain in detail. But what I want to say is that, of course, being able to do this analysis doesn't spare us from the job of then communicating. So science communication will continue to be a challenge. It will be around the EHDS as well, when we try to get this on the ground and to get the public behind this new thinking about reuse and secondary use of data. So I'm really looking forward to trying to achieve that with all the people we have at our disposal.
Thank you very much. That's really important. It also reminds us, and this is what we live and breathe with every day at the Observatory, that having the right evidence and trying to communicate it effectively does not necessarily guarantee you that it will influence policy in the evidence-informed way. I don't know if, Kate, you have any final reflections you want to give us. We only have an hour, sadly, for these webinars. Otherwise, we could stay here for a while, I think, before we close.
Just to say thank you so much for this panel and for organizing it, to Erica as well, and to Dimi and to the colleagues here. I think what I've taken away is that there are lots of synergies and a lot more to do, obviously, but really where the European Observatory can support your important work. And then this interesting dichotomy between the science communication for policymakers, but then also the users of it. And when we're talking about digital health data, that and the cultural attitudes towards the use of personal data, that will be increasingly important. So
thank you very much. I think this is excellent signposting also of our commitment at the Observatory, and the loads of work we still have to do in that area moving forward, same as other colleagues around the virtual table. Our door, or rather our mailboxes, are always open if you, our participants, want to reach out on any of these issues, and we look forward to working with all of you here on the panel and all of you here in the chat box on this crucial issue in the next years. Thank you all very much for coming. Thank you for joining us, and we see you soon. Actually, in 2 days, on Thursday, for our Jubilee event with the Observatory, celebrating our 25 years. On our website, we have a link for that. Implementing innovations in healthcare. Part of that, of course, data and data availability and digital health. So if you're interested, see you Thursday. Otherwise, next webinar to come. Thank you all very much. Goodbye.